So welcome everybody to this Women in Sport Surgery panel event. Our goal for this event is to shed some light on what it's like to be a female sports surgeon, having gone through training in orthopedic surgery, in which only 6% of practicing surgeons are women, and then also having gone through a training in sports surgery fellowship. I found some research showing that as of 2020, sports surgery is the third most popular specialty for young female orthopedic surgeons, behind hand and pediatrics. So we absolutely have a contingent of young women who are either considering sports surgery as a career or, like me, have already chosen it and are wanting to hear some career wisdom from their predecessors. So I have invited 5 giants in orthopedic sports medicine here today, each of whom has been successful in her own way. And I have asked them to speak about various topics related to being a female sports surgeon, and I'll introduce each of them briefly before they present. So without further ado, let's get started. Okay, we have Dr. Gabriella O'Day. She is in practice at Prisma Health. She completed medical school at Rush Medical College. She completed orthopedic surgery residency at Atrium Health Carolinas Medical Center, and then a sports surgery fellowship at Hospital for Special Surgery. She is the most fresh out of fellowship, but has accomplished a lot in her time since completing fellowship. She is currently the team physician at Clemson University, working with volleyball and women's basketball. I look up to her as an alumna of the program that I'm currently at, and I've asked her to talk about lessons that she's learned in her early career so far. So Dr. O'Day, take it away.
All right, thank you, Dr. Shing. So the question that you had asked me was, what issues do you think young female orthopedic surgeons are facing or going to face in sports surgery? So when I really thought about this topic, it really kind of boiled down to establishing your early professional identity. And I think there are different steps that come with that. And we'll kind of talk a little bit more about each of those kind of major milestones that are faced. From the perspective of somebody who is, 4 years removed from where you were applying for sports fellowship, kind of that first big hurdle is trying to figure out where your ideal sports medicine fellowship would be. And probably one of the biggest questions to ask yourself is, what clinical exposure do you want to have? There's so many facets to sports fellowship. And I think that was one of the things that drew me to sports medicine, is that you can have a specific focus or a broad interest in different areas, different body parts, whether it's shoulder, and that can include arthroplasty, throwing shoulder instability, arthroscopy. The knee has many different areas, including patellofemoral, cartilage restoration, pediatric ACL as well, hip preservation, the elbow, as well as some fellowships who offer opportunities with foot and ankle sports medicine as well. Another factor to consider is going to be surgical volume and complexity. And those aren't always mutually exclusive things, but certainly you want to consider, do you want to be at a place where you're getting a lot of reps? Is that something that you feel is a need for you coming out of residency? Or is your focus more on doing certain cases that are a little bit more complex and a little bit more nuanced or niche? And sometimes you can have some programs that have a lower volume but a higher complexity, and that may be a better fit than a program that has a lot of surgical volume but a more sort of basic sort of sports experiences. What's your surgical autonomy going to be? I do think day one autonomy is not always a good thing in fellowship, but neither is 365 days of observation. So trying to find a balance and trying to understand what that balance may be is important to tease out when you're evaluating different fellowships. And also, what are the clinic expectations? Certainly a fellowship that touts that you never go to clinic, that is not a good thing. Much of what you learn about indicating your patients and your doctor-patient relationship and rapport with patients is what you learn from your mentors in fellowship, and how, their decision-making process to say surgery or no surgery, or this is the next best step for you as a patient. So having that balance with clinical experience is also important. Team coverage. Do you want team coverage, and at what level? Do you want to have the experience of a pro team coverage, which I was lucky to have both pro and college team coverage in my fellowship. Do you want to cover high schools? Do you want no team coverage if you feel that you'd rather focus on your surgical experiences and don't have an interest in being a team physician? There are many, many wonderful sports surgeons who do not cover teams. I would say the majority often do not, and they have robust practices as well. What are the research expectations for that fellowship? Do they want one abstract, or do they want 20 papers? And what is your interest from that standpoint? Resident fellow relationship is also important to consider. Is if a program has a residency associated with it, are you going to be a teacher to that resident, or are you going to be a case competitor? Are you going to be double, triple scrubbed? And how do you make the best out of those experiences? And certainly mentorship and job placement is an important factor. Who do you think you could call upon for advice on your practice day one? Who's going to make phone calls for you to get that first practice? And much of that you can tease out by talking to current and previous fellows at a program and asking them who's the person who goes to bat for you in this fellowship. And do you feel like you can have that person as a mentor for you for really lifelong? And even though fellowship is just a year, these are going to be lifelong mentors for you in your practice. And then do you have any post-fellowship training interest? Do you want or need additional exposure to another subspecialty, whether it's ped sports medicine or foot and ankle, or additional shoulder experience, whether open shoulder or arthroplasty? These are things to factor in. And does that fellowship offer you those connections or opportunities to do that? Okay. And then that next big milestone is going to be selecting your first practice. And these are things to consider when you're a resident and also in your fellowship. And certainly a big factor is location. What's ideal for you? What are factors to consider? Certainly weather is important, as well as cost of living. Where is your office and hospital going to be located? Are you traveling between multiple hospitals? Is that something that is feasible for you in the short term or long term? What's the practice model that's ideal for you, whether it's hospital employed or private practice, or is it a small private group or a large private group? If you're considering academic practice, then there's a lot of other different factors to consider. What are your teaching expectations? Are you teaching residents, fellows, medical students? What are your research expectations? And what's the infrastructure to support that? Is there incentive for research productivity? Do you have protected research time? And that was a great piece of advice that Dr. Hannafin gave to me when I was a fellow, which was, really, if you want protected time to be productive in research, you need to ask for that time, and speak now or forever hold your peace. It's very challenging to ask after the fact for a half day or a full day dedicated to research when you're already in your position. And it is very valuable to ask for that time up front. And it's, as somebody who has done that, I use my research days and I value them very importantly to be productive. And then what leadership opportunities are available for you in your practice, what support and sponsorship do you have with leadership in that practice? And also, what are the practice needs? Can you find a niche in that practice? Where are the referrals coming from? Are you going to super specialize in specific areas and have specific focus, whether if it's, a specific joint or specialized care, including women's sports medicine or arthroplasty? All of these things are things to consider as to where you want to kind of fine tune your practice and what works for you. Even, things that to consider: a compensation model, what your growth potential might be, what support staff do you have? Do you have OR time guaranteed up front? And sometimes that is not always a guarantee, but trying to understand where you're going to operate when you get these patients is important to know at the start. And then again, are there team coverage opportunities, and is that a priority for you at all, or early in practice or in the future? And then ultimately, the big question is, when you've kind of passed that threshold through fellowship, there are many things, that I feel like I've learned, or I wish I'd learned over the last 2 years in practice. And much of that is building your reputation in your community, how to refine your surgical practice, having an efficient, effective OR environment, and also remember to cut yourself some slack. So speaking on that first point, building your reputation in your community, things I've learned is you want to reach out to medical practices and urgent cares within your referral base, introduce yourself, provide contact information, offer lunch and learns or educational sessions. You're the new dog in town, and in order for those practices to kind of know who you are and know your expertise, you have to go out there and introduce yourself, and certainly explore all marketing opportunities that are available to you through your practice website, or as much as what Dr. Yen Shipley talked about, social media or a personal website. You can get patient testimonials, and certainly encourage happy patients to write a review online for you, because much of the challenge early on in practice is you don't have enough ratings. So in a way, you're an unknown entity, which sometimes can scare off patients if they don't know if you're a future 5-star surgeon or a future 2-star surgeon. So, when you see those happy patients, certainly encourage them to give a good review for you, so that you can build up that reputation in your community. Another big thing is refining your surgical practice. And one thing I've learned is follow-up is your friend. See post-op patients early and often. For me, that's important because, when you're in your own practice, what does a 1-month ACL look like? What does a 2-month cuff look like? What should you try and factor in is something that, hey, I should be concerned and see this person again sooner, or this is expected and normal in their post-operative course. And certainly following patients out further at first was very helpful, both operative and non-operative patients, so that you can kind of gain experience to know what the natural history of their disease or pathology is, and be able to reassure future patients about things that normally don't concern you because you've seen it kind of far out longer than maybe you follow anymore. Certainly finding your external referral partners is particularly important for women's sports medicine. Who can you collaborate with primary care sports medicine, bone health, nutrition, sports psychology, and psychiatry. So when you have patients who have, issues outside of their specific orthopedic problem, you can certainly refer them to somebody that you trust and really is on the same page with you and can help with those other issues. Also remember your local physical therapists and athletic trainers are your friends. Introduce yourself to those faculty members pretty much as soon as possible. Make sure they have your contact information because they're your post-operative eyes and ears. And also review your PT protocols and really update them annually, and discuss return to play criteria with those people, because if there's any ambiguity, you want to make sure that everyone's on the same page so the patient knows that you are in communication with their therapist and they can trust the process and their recovery. One thing that I strongly encourage is starting collecting patient-reported outcomes on day 1. At a minimum, a pain scale question or a single-eyed assessment like a SANE score, which asks what percentage of normal is this body part, is very helpful. One, it helps provide you some objective insight on how your patients are doing, and again, gives you perspective of how you'd expect them to be at 2, 4, 6 months or a year. I also found that it's been a great personal antidote for imposter syndrome, because as you're seeing these patients along and you maybe question, hey, am I a good surgeon? Am I, doing the right things for these patients? And then you see, hey, I saw this person, they're 1 year out from their cuff and their SANE score is 95% of normal. Hey, I really feel like I did a good job for this person. And you can kind of give yourself a little bit of a pat on the back. And also kind of just give yourself objective feedback of how you're growing as a surgeon as well. Also, continued education is your friend. Attend academic meetings, go to cadaver sessions, scrub with senior partners who may be more experienced in certain areas. You're still learning. You're not going to be at the absolute pinnacle of your knowledge base and your skill set day 1 in practice. It is still, that's why it's called practice, is that you're going to continue to grow and learn every day. And so take those opportunities while you have them and really seek them out. The next big thing is developing an efficient, effective, and respectful OR environment. Build your preference cards before you start practice. Poaching them from your fellowship mentors is definitely, I would say, a pro tip. Meet the OR nursing, anesthesia, and pre-op leadership, and certainly encourage open lines of communication that will help troubleshoot any future problems or areas of improvement. Things, when issues are come up, how do you facilitate change and make sure that your cases are starting on time, that your patient, there's good communication between the staff, and if there are issues, that you can cordially and respectfully resolve them with all involved parties. Certainly early on, always be present for patient positioning, prepping, and draping. That shows that you're part of the team, but also knows that the OR team's meeting your standards every time. And I think this is a big one. Own the surgical timeout. I think this is critical as a female surgeon. This is your time to show that you're in command of your room and ensures everybody's on the same page. I like to give approximations of the surgical time, and if I'm expecting a longer than usual time, I will let them know at the start of the case, but also give yourself a generous estimate. If you're, don't tell them you're going to do a 30-minute rotator cuff and then all of a sudden it's 2.5 hours later, then everyone's looking at you like, what's going on? And so, give yourself some generosity to those times. And so if that way, if things run a little bit shorter, then everybody's in a little bit of a better mood at the end of the case. Certainly define your assistance role, and that's important for arthroscopy. Who's holding your scope, who's passing your anchors, who's passing your ACL grafts. And much of that you just kind of have to learn along the way and really watch and follow those nuances of those things when you're in fellowship. Take copious notes, write down steps after your cases, because they will help with future mental preparation and makes the next case a little bit easier. And certainly very important, be kind and respectful to everyone. Stuff happens in the OR. You got to stay calm, even if things aren't going your way, because your team will feed off of your energy. And if you're flustered and you're taking it out on the people in the room, that just makes the case longer and harder for everybody. Debrief after OR cases to the end of the day, particularly early on, and really tease out what went well, what could be improved. Did I need, are there certain instruments I needed or unnecessary? And then update those preference cards as needed. And then the last big thing is cut yourself some slack. Practice makes perfect, but practice also makes more practice. There really is no perfect. This is a continuing evolving field, and where you are on your first day in practice, where I am in my first day in practice is not where I am right now, 2 years in, and certainly I hope not where I am in another year, 5, 10, 15, 20 years. And also remember that sports medicine is elective practice. So remember to do the right thing for the patient every time. And sometimes it's hard, but ignore that external pressure from patients or competing practices to do something that you don't feel comfortable with, whether if it's an unindicated surgery or something that the patient is pressuring you to do that you feel is not appropriate for them. But at the same time, don't abandon patients. You can politely say, I just don't feel that this surgery is in your best interest. I don't think I can make you better with this surgery. But if you want a second opinion, here are names of a couple people that I can refer to you that I trust and I think can give you a good, honest opinion. If you tell them that and tell them, I'm always happy to see you back, then you've left the encounter respectfully, but have not felt that you had to sort of bow to a pressure to do something that you didn't feel was right for that patient. And remember, you're going to be inefficient at the start. So learn from every case, every mistake, own your mistakes, but don't get handcuffed by them. And you can't predict how your practice will evolve. When I started practice about 3 months into my practice, COVID struck. And so you sort of have to go with the ebbs and flows with how things and, hospital contracts changes. There can be budget cuts. So you have to remember to go with the flow and remember to be dynamic and remember to sort of evaluate where you are and to do what makes you happy. And ultimately that will sort of guide you along as you continue on further into practice. All right, thank you.
All right, thank you, Dr. O'Day. Okay, next up we have Dr. Nancy Yen Shipley, who is in practice at Multnomah Orthopedic Clinic on the West Coast, joining us today. Thank you. She completed medical school at Drexel University, orthopedic surgery fellowship at VCU, residency at VCU, and sports surgery fellowship at Orthopedic Research in Virginia. She is also a team physician with US Ski and Snowboard. She, in addition to having a busy practice and being a mom, runs a blog at nancymd.com, which is talks about the challenges and also the bright spots of being a woman in medicine. And she also is the creator and host of the 6% podcast, which features women in traditionally male-dominated careers and fields who have overcome challenges and adversity to thrive in their careers. So she's going to talk to us today about expanding social media presence for female orthopedic sports surgeons.
Thank you so much for that introduction. I feel like I'm on here on stage with some big giants of sports medicine within orthopedics. So thank you so much for having me on. As you mentioned, I'm in private practice here in Portland, Oregon. I'm about 10 years out of training. And a little bit of background of how I ended up being interested in social media and how I ended up here. So I joined my private practice 10 years ago out of training, and I was shocked to find that we had no website, zero. And that really wasn't all that long ago. So I got into building a very basic, bare bones, pun intended, I guess, website, and learned the basics of that. Along the way, I learned a little bit about SEO, search engine optimization, and just kind of visibility online. And that then turned into my interest in social media when I started to run my own public profile on a couple of different social media platforms. Now, of course, my practice has an actual professional website, thank goodness. But it was an interesting springboard to get to where I am now, as far as, kind of having social media within orthopedics as an area of interest, a little bit non-traditional beyond my clinical interests. So, as Dr. Shing alluded to, there are currently only 6% women practicing in orthopedics. And that led to my interest in exploring other fields and professions in which there really aren't a lot of women, and what our common experiences are. And that was the inspiration for my podcast. Over the past couple of years, I've become very active with my public social media presence, vocal about the use of social media among physicians and specifically within orthopedics. I talk a lot about diversity, equity, inclusion, anti-harassment, anti-bullying within our field, and in general, just culture change for the better within our great specialty of orthopedics. So for the participants in this webinar, I'm sure that being on ViewMedi, there's probably going to be a pretty good idea of the using tech and what social media is. But what isn't always obvious to the orthopedic surgeon is how to best use social media. I think that there are a lot of barriers. There's a lack of familiarity among some, level of comfort with tech in general, perceptions of what social media is and what it should be in a medicine setting, in a professional setting, and of course, always time. So why should we be on social media? There are lots of reasons. One is to have a little bit of broader reach with the general public. We can use it as an adjunct, as a way, an alternate way to reach our patients. We can connect with our colleagues, and many of the others on the panel here I've connected with online. A few I've met in person, others have yet to meet in person. Marketing your practice or your institution, getting public health messages out there. There's also virtual mentorship. A lot of individuals are on social media looking to prior generations in orthopedics for mentorship and leadership and guidance. So when we want to think about reaching the general public, there are different things that we can think about. You can educate, you can share valuable content, you can answer common questions. And what's become glaringly obvious in recent times is that this is a good way for us as people with real credentials, actual education training, to combat misinformation. So we have an obligation in the social media sphere to counteract what is inaccurate as far as healthcare and science goes. So I think we have an important role there. As far as reaching our patients, it can expand the reach of existing resources. You may see your patients in clinic. You may have handouts there, but nowadays, so many more patients are becoming savvy and they're online, and it's just a nice way to expand what you can offer to your patients. Social media is also a really great way to connect with your colleagues. You can see how even the academy is getting in there with the social media task force / now committee. It's a great way to have interesting academic discussion between physicians even. it's another way to market your practice. If you are in private practice, or a way to expand the footprint of even your academic institution, getting onto social media, depending on how you do it, can increase the searchability, how far up on the Google page you pop up when somebody searches shoulder surgeon or searches, rotator cuff surgery. You can also help establish yourself as an authority and also solidify your brand. A lot of physicians sometimes are really surprised. You hear a lot about branding and you think that's for Starbucks, that's for whoever and all these other corporations, but physicians really need to have an idea of what their brand is, because having clarity of that actually helps guide a lot of your decision making in this sphere, beyond clinical, of course. And of course, virtual mentorship, as I mentioned. A lot of folks think that, especially among, more seasoned generations, think that their generation is not on social media, but it's increasingly becoming very commonplace to be on social media within all age groups. And it's important to understand that your voice matters on there. Couple things I want to touch on. Number one, best practices. There are definitely some primary obligations to consider when you're engaging in social media as a physician. Confidentiality, of course. HIPAA definitely exists online. Boundaries and just overall professionalism. And this is all, fairly, just kind of interpreting this in the context of social media is fairly new territory for a lot of us. We obviously want to follow HIPAA when we are online, use the same guidelines, same rules that you would use in real life. When we share images, when we share information, even if it's for academic purposes, we want to make sure we're still getting consent for that. If we're sharing x-rays or cases, a lot of surgeons will not post cases the same day that they did the surgery, just to kind of have some temporal distance between the time that they perform the procedure to when they're actually sharing it. And it's important to remember also that social media is not a means for communicating with patients. I think that most of us know this, but a lot of times individuals who are your patients may not fully recognize that private messaging in a social media platform is actually not appropriate for communication between patients and physicians, and that it's not HIPAA compliant, it's not secure. We need to think about boundaries. It's our responsibility to maintain those boundaries, not the patient's, right? And so we need to make sure that we're maintaining appropriate boundaries in that physician-patient relationship at all times, even online and even with electronic media. Now, sometimes that line has the potential for being blurred, because especially if you are practicing where you live and your community ends up, you end up knowing someone who knows your patients, maybe it's a personal friend. And so your patients may follow your public platform, but may also try to locate your personal profile and try to friend you. And I generally will tell surgeons and other people in medicine that if you have a private platform, keep it totally separate. Don't friend your patients. Don't friend your staff even. I really try to keep that line there. I did have a patient, as an aside, ask me if it was okay with me that she followed me on my public platform, Twitter it was. And I said, if this is a public account, you can absolutely follow me. You just have to bear with my sense of humor on there, and it's totally fine. And also professionalism. We need to remember that what we put out there in social media affects our online reputation, and we want to be careful with negative statements about other healthcare professionals, other fields. Use caution when responding to the negative comments of others. Always err on the side of caution. And of course, we're seeing more and more conflicts of interest on social media among those in healthcare. There are some individuals who get really large followings, and as a result, the marketing people from different companies, whether it's scrubs companies, or whatever, what have you, will ask for promotional content to be made and to be placed on your platform. And it's just important to make sure there's disclosure of financial relationships. I won't, say anything or pass judgment on whether or not that's appropriate, but just keep in mind that the FTC does require disclosure. And of course, just like with anything else, we want to be careful that nothing we're saying is interpreted as medical advice, and be cautious about medical claims. The FDA certainly regulates that. So I want to wrap up a little bit and not go over time too much. It's important to think about your goals being on social media. You want to choose your platform, where you are, whether it's Facebook or Twitter or Instagram, depending on whether you're looking to expand your academic connections, work on educating the public. Do you want to reach out to your patients? Is this for community benefit? Is it for fun or entertainment, or just connecting with colleagues? You want to choose your platform based on where those individuals are. Think about where your audience lives and demographics. It's very easy to find this data online, age breakdown, other, gender, geographic location, interests. You can find that easily online with a quick search, which platforms tend to cater to what demographic. And there are so many options. It's mind-boggling, and sometimes it's hard to know where you start. I would say that if you're in practice, it's a good idea to make sure you just have a nice, clean looking informational website so people know where to find you. It's a good idea to start with a Facebook page, a business Facebook page. It doesn't have to have a whole lot on there, a way to connect with you, a way to contact you by phone, etc. It's important to have a business Google profile. And then if you're ready to take that next level jump, then you can dabble a little bit in Instagram and Twitter with a public profile. It's not that hard to do. You can always find help. If you're a DIY kind of person, there's a lot you can do to tinker with your own social media platform. But if you establish what you want your public brand to be and to feel like, then you can always get help, because we all know that we get busy with life and family and our clinical practice, and we certainly don't want to neglect any of that for the sake of social media. But I think it's a really nice adjunct to have as part of your practice and as part of being an orthopedic surgeon. It's definitely enriched what my experience in practice has been. So in summary, make sure you use social media. Don't let it use you. Know what your goals are, understand where your audience is and where the people that you want to connect with are. Don't forget to show a little bit of your personality on your public platform. That is okay, but remember professionalism as well. Thanks for having me.
Thanks for that talk, Dr. Yen Shipley. That was awesome. We're going to have Dr. Joe Hannafin from Hospital for Special Surgeries. Dr. Hannafin has a long list of accolades that I can only summarize here briefly, but she obtained her MD PhD at Albert Einstein, and then completed her residency in orthopedic surgery at Albert Einstein as well. She then completed a 2-year fellowship at HSS, worked as a clinician scientist at HSS from 1992 to 2021, and just recently retired in May of this year. So congratulations, Dr. Hannafin, on a long and industrious career. She still is associated with HSS as vice chair of the IRB and is senior advisor at the Women's Sports Medicine Center, of which she was a co-founder actually. During her career, she also was a team physician for the New York Mets, New York Power, WUSA, WNBA, New York Liberty, and for US Rowing for an impressive 27 years. She was a 4-time Olympic physician, was the first female president of AOSSM back in 2014, was admitted to the AOSSM Hall of Fame just this past year, and was the first female to receive the Robert Leach Award from the AOSSM also this past year. So we're going to hear Dr. Hannafin talk to us about what the functions of a women's sports medicine center are, what considerations one needs to have in order to create or be a part of a center like this.
So what I'd like to talk about is really how you provide comprehensive care for active women. So Title IX, which actually happened my freshman year in college, changed women's sports. It increased access to athletic programs, athletic scholarships became available for women, and really had women participating in multiple sports at the collegiate level, high school level, club and travel teams. And that has expanded over the years to CrossFit, gym-based fitness, cyclists, runners, skiers. And this influx of female athletes has been accompanied by a significant increase in athletic-related injury and an awareness of the female athlete as a patient. So in the early 1990s, when I started my practice, there was really a limited awareness of sex differences in musculoskeletal injury. And there was no understanding of the importance of lifelong athletic involvement in fitness for girls and women. In 1993, I met Dr. Lisa Callahan, who was interviewing at HSS for a family medicine sports position. And we brainstormed one afternoon, because it was early in both our practices, and I had hours to sit and chat with someone. And we talked about the issues and the kind of patients we saw. And we were seeing predominantly female patients who felt that they had been dismissed by some of our male colleagues. And so we decided at that point to develop a program, which at first was just two of us. We worked on a business plan and created that to demonstrate that this was feasible to have a hospital-based center, which would ultimately encompass patient care, research, outreach, and education. And that was launched in 1996. So when we opened at first, we had one orthopedic surgeon, one primary care sports physician, and one physiatrist. In the lower left corner of the lower picture is Deborah St. Fard, who was actually a shot putter for the Haitian Olympic team, who was with us for several years and went on to start the women's sports medicine program at the University of Colorado. We had a nutritionist, we had physical therapists, exercise physiologists. And we took that first picture, and it really dates us because we're all in track gear. No one would wear a tracksuit like that now, but in those days, that was actually pretty cool. It was the Women's Sports Medicine Center track gear. And we photographed ourselves with our favorite sports equipment, and that hung on the wall of our office for quite some time. Next slide, please. So the core values and the mission of the Women's Sports Medicine Center, which I think can apply to anyone who starts this kind of program, was first to provide the highest quality interdisciplinary care to physically active women of any age, race, color, sexual orientation, creed, or ethnic origin. Second, to advance research in areas related to physical activity, health, well-being, quality of life, and sports performance in women. Third was to provide mentoring opportunities for young women related to health, fitness, performance, and sports medicine. And we do that through a summer fellowship. To exhibit national and local leadership in sports medicine, and to provide educational outreach to our colleagues, our patients, and the community. Next slide. So our current staff is much larger than it used to be. We now have 4 active orthopedic surgeons. I am the emeritus member, 3 primary care sports medicine physicians, 1 physiatrist, sports psychologist, 2 nutritionists, an exercise physiologist, 2 strength and conditioning specialists, and 2 physical therapists. And what's interesting about this group is that we take care of more national teams than all of the 115 orthopedic surgeons in our institution. Karen Sutton, who you'll hear from later, is one of our partners who works predominantly in the Stanford office. She takes care of USA Lacrosse and USA Ski and Snowboard. Daphne Scott, who is our sole African-American partner, family medicine trained, works with USA Track and Field. Ellen Casey, who is a physiatrist, is now the new head physician for women for USA Gymnastics and is really working very hard to change the culture and change the way that fitness and training are tracked in gymnastics. Marcy Goolsby has taken care of USA Biathlon. And then Lisa Callahan, my original partner, was an Olympic physician in 2016, taking care of men and women's basketball. So in terms of, next slide, please, professional education, we have done outreach to small groups. We had a course that ran for a number of years, which we're due to restart again for physical therapists and primary care physicians. We do community outreach. We have an internship, which was funded by the father of 5 daughters 12 years ago. We have 3 positions a year with over 150 applicants each year. And in the tracks, there's a first-year medical student, a pre-medical student, and someone who's interested in physical therapy, athletic training, or the performance track. And the picture on the top there, a woman to the left of the photograph is a resident in physiatry, and the woman to the right of the program is an MD PhD student who's applying for orthopedic residency as we speak. We cover local, national, international events, a lot of women's running events in New York City, the School of the American Ballet Theater, and we've been involved in the Perry Project since its first year. And that was started by Summer Hamoud, who's a sports medicine physician at Rothman, and actually the first female partner at Rothman, who came after hearing the Perry Project being presented and said, "Doc, we have to do this." She organized it all, and it's done every year since then as a real result of Summer's enthusiasm. Next slide. In terms of research, we have a very large patellofemoral program, which is run by Beth Schubenstein. We do return to sport assessment, and there'll be some papers coming out shortly looking at a multi-system approach to determine return to sport. We have physicians working in the area of metabolic bone disease, disordered eating, and REDS. Karen's been working on adhesive capsulitis and breast cancer treatment. And Ellen Casey is particularly interested on hormonal influences in neuromuscular behavior and injury risks, as well as epidemiology of both gymnastics and soccer injuries. Next slide, please. So what are the benefits of a program like this? Well, the goal is comprehensive care by physicians and staff who understand and more importantly, respect the needs and lifestyle of active women of all ages. And that could be a teenage female ACL patient, a collegiate or professional athlete, a pregnant or post-pregnant athlete who has issues with core stability, and middle-aged or even older athletes in their 70s to early 80s. I have an 80-year-old powerlifter who goes to these World Masters games as a powerlifter. And the model of care has also been appreciated by the male patients who come to see us at the Women's Sports Medicine Center. And I would say probably 25% of our patients are men, often husbands, brothers, or fathers of patients we've taken care of. And what it does, the fact that men are interested in coming to see us at the center simply reinforces the need that comprehensive and multidisciplinary care is important for all athletic and active patients, not just women. So who benefits from this? The patients, clearly. The physicians do. We have a wonderful group of people that work together. The institution does because of referrals. And it's also just a fun way to practice. And why is it important? Well, we now know there are clear sex differences in male and female sports injuries. And there's been a recent increase in epidemiology studies reporting sex as a variable in injury, which is promising. Summer and I published a paper, gosh, it's probably 9 years ago now. We looked at 5 major journals, and we looked to see whether sex was listed as an independent factor in injury. And only 30% of the journals had that as an independent factor. And it was actually turned down by the JBJS and the Yellow Journal because they thought we had an agenda, which we did. But CORE took it, published it in CORE, and Mary Mulcahy has repeated that study. And unfortunately, it's still only at about 35%. So there's still work that needs to be done to make certain that people report sex as a variable in injury. And so my plea to everyone is sex should be reported as an independent variable in all studies, whether clinical, translation, or basic science. And data is lacking clearly in the role of sex in injury prevention strategies, in surgical indications, in clinical outcomes following surgical management. And thank you very much.
All right, thank you so much for that great talk, Dr. Hannafin. Okay, next we have Dr. Karen Sutton, who is currently practicing at Hospital for Special Surgery as well. Dr. Sutton completed medical school at Maryland, her orthopedic surgery residency at Yale, and completed 2 fellowships, one at Harvard Mass General for sports surgery, and then another in pediatric sports surgery at Boston Children's Hospital. She is the head team physician for U.S. Women's Lacrosse and the chief medical officer for World Lacrosse, as well as a team physician for U.S. Ski and Snowboard. And then, as Dr. Hannafin already mentioned as well, she is a member of the Women's Sports Medicine Center at HSS as well. And I've probably tasked Dr. Sutton with the most difficult topic of tonight, but it is one that came out of a conversation she and I had when she came here to CMC, Carolinas Medical Center, as a visiting professor. We were talking about some of the challenges that being a woman in orthopedics presents, and she said to me, bring your diversity to the table. And that really resonated with me, really stuck with me. And so I wanted her to kind of expand on that a little bit in tonight's presentation. So I'll turn it over to Dr. Sutton now.
Thank you. Happy to discuss it. And I also wanted to acknowledge my research assistant, Dakota, who's helped with this too. Bring your diversity to the table. One thing that I noticed, as you've heard both Dr. Hannafin and Dr. West speak about, is just understanding our pathways through orthopedics and our career. And I think you can see both of their personalities shine through in terms of how they handle things and, you know, the extreme talent that they have in their profession. And it's certainly, you know, an honor to sit on this panel with them as well. But I was at an ESPN conference one time and working with a few people to go over a talk on being in male-dominated, for them it was male-dominated sports. And I was able to have a conversation with Danica Patrick, who, as we know, was one of the famous race car drivers or NASCAR drivers in certainly a male-dominated field. And one thing I asked her was just, you know, what do you think about your confidence as you go up to the race? Do you feel like it's difficult being in that very machismo profession, and all the guys are beating their chests and saying, you know, I can do this, and what are you doing here? And one thing that she told me was that in general, she felt like women tend to need to be a little bit more prepared coming into things. And she felt like she felt very comfortable, you know, participating with all the men and being out there. But she did feel like she had to take a lot of extra steps to prepare more than she did her male colleagues. So, you know, this all stemmed from, I think you heard me speak one time, Elaine, where I was saying when we went into residency, and one of the big cases you do is femur fractures as, you know, third year, fourth year, fifth year, and you go in and you do the case with your trauma surgeon or whomever, and it's difficult. You're reducing the fracture, you know, reaming out the canal, making sure you have the right placement in the canal, and putting whatever hardware you need to put in there. And I was coming out of these cases like, wow, that was really hard, you know, reducing the fracture and moving the X-ray around and making sure you have, you know, the perfect entry point. And so every part of the way, I just felt like I was thinking and stopping and pausing. And I would get back to the residency room, and, you know, my residency colleagues would be there, and they were like, oh yeah, I did that femur fracture all by myself from start to finish. The orthopedic surgeon was down the road at the coffee shop, and just the stories got bigger and more grandiose. And I was sitting there like, wow, really? Like they were really at the coffee shop. Okay. Like I felt like I had one hand on deck, like holding the mallet up to reduce the femur, one hand on deck, just, you know, making sure the guide wire was passing correctly, another hand on deck, retracting. And I definitely don't recall anybody being in the coffee shop. So I think in general, just feeling a little bit nervous before procedures, or feeling that you need to prepare a little bit more for procedures is completely appropriate. Your nerves and your endorphins, it's like starting a race, and the more you can be prepared, the better. That's where that all comes from. And to give some background, as Dr. West pointed out as well, as orthopedics is a heavy male-dominated field, and 14% of residents and 6% of academy surgeons, active fellows, are females. It's a result of many factors, including comfort and confidence. At HSS, we looked at this study with a few of my colleagues in terms of testing by manual suture skills of 216 orthopedic surgery applicants. These are medical students going into residency or applying for orthopedic residency. 158 were male, 73%, and 58 female, 27%. And on average, females scored themselves lower than males on both pre and post task evaluation scores. In other words, how are you going to do going into this task where they had to suture different things? And then how did you feel coming out of it? And there was a trend towards statistical significance pretty close. I think we can increase our power, but most likely a result of the limited female population in the study. But in other words, I think that there could be potentially a different way to teach orthopedic surgeons and residents and potentially instill more confidence. When I talk to some of my friends who have worked with the Navy SEALs, they usually do kind of like a pre-op briefing before they're going on duty, and then they go through a debriefing. And there's a lot of conversation and analysis. And that's where, you know, potentially doing that in some of our training could come to play. Owning your space, I think this is important. Embrace what makes you unique. It's a little bit easier as we get further into our practice, and bringing in what really makes you somebody who your patients want to come to. And I think when you're a resident or when you're starting out your practice, you do have to make sure you blend in a little bit more. But then I think once your practice is a little bit more established, people do start seeing you for you, unless obviously you're a trauma surgeon. But I think they do tend to seek you out with your background and your team and the people that you're working with. And from my background, just working with a lot of the lacrosse teams, having played lacrosse at Duke, and one of the goals I set was to start working with US Lacrosse and trying to figure out the pathway to get there. It was helpful, and being able to relate to athletes and relate to, both female and male athletes, and then be able to deal with injuries with them, I think was certainly a great asset to being able to work with those teams. And focus on your strengths as well. Who are you as a family person with sports, hobbies, passions? Patients like to see a little bit of small talk back and forth, and they, if you can relate to them, I think it is helpful. You're going into surgery, and a lot of times my athletes are young female athletes, and there's a lot of times that parents say, look, they feel more comfortable with you being out there. And just this past weekend, I was training on a run, and I passed, the person I was running with pointed out a Duke hat on somebody that was walking, and I was wearing Duke shorts. And so I said, hey, go Duke. And they're like, Dr. Sutton? And I said hi, and it was a patient's mom and dad. And the mom started crying. She's like, I just want to give you some feedback that this girl, you did her ACL reconstruction, and she had trouble getting back to tennis right away, but she ended up a faster skier. But what we really want to tell you is that she accepted an offer to Duke to row crew there, and you were a big inspiration in her life. And they were like, can we take you out to dinner sometime? So it really, it's a bigger story than just taking care of patients. And then become the captain of your ship, understand your unique leadership styles and how you can limit stress during unforeseen events. So in other words, my brother certainly believes in transcendental meditation, but if there's ways that you can calm yourself before cases or be prepared, that's very helpful. Growth and development through programs or groups. I find, really being a part of the Women's Sports Medicine Center, being a part of AOSSM, AAOS, that's really helpful in building myself as an orthopedic surgeon. So I just want to say thanks. These are my teams. My big team on the left is my 4 children who are in middle school and elementary school now, and then US Lacrosse, the men and women, as well as US Ski and Snowboard. So thank you.
Thanks so much, Dr. Sutton. Next, we have Dr. Robin West, who is practicing as part of the Inova Medical Group. Dr. West completed medical school and residency in orthopedic surgery at George Washington University and completed her sports surgery fellowship in Pittsburgh. She is currently the chair of Inova Sports Medicine and is the head team physician of the Washington Nationals, is also the former head team physician of the Washington football team and former assistant team physician of the Pittsburgh Steelers.
Thanks, Elaine. So I'll be talking about considerations for the female team physicians who take care of male sports. So there's a gender divide in orthopedic surgery, as Elaine talked about earlier. From an AOS survey in 2019, only 6.5% of practicing orthopedic surgeons are women. The number is slowly increasing as 14% of orthopedic residents are women. Orthopedic surgery shares its low percentages with the Department of Labor's jobs that are classified as traditionally male: machinists, welders, and firefighters. This recently published study in AJSM showed that women represent 7.7% of all team physicians, including primary care and assistant team physicians in the NCAA Division I conferences, and 6.3% in select professional teams. This recently published study from JAMA in 2020, they assessed head female team physician representation at all levels of the NCAA. In the 2018 to 19 academic year, 11.2% of head team physicians were female, but yet female athletes made up 44% of all athletes. So Dr. Wesner at the University of Alberta wanted to determine if male and female athletes have a preference regarding the gender of their team physician. The stereotypical perception is that it must be awkward for a female physician taking care of a male team. And this was what prompted her to do the study. So her group sent out 365 questionnaires to the University of Alberta athletes, and they had 164 questionnaires returned. And the results showed that all females would prefer a female team physician, and 94% of males did not have a preference, whether they had a male or female team physician. So from her study, both men and women said that it was important for the team physician to be sympathetic, caring, understanding, respectful, be a good listener with good communication skills, as well as compassionate, trustworthy, and sensitive. And only 8% of the men and no women thought that men were more sympathetic and caring. So Dr. Wesner said that it appears that it's stereotypical mothering, or this nurturing aspect of the female personality, that male athletes appreciate. You know, it really takes a village. You're part of the medical team, but you're certainly not the most important as a team physician. The athletic trainers, the physical therapists, the strength and conditioning coaches, everyone plays a role, and you have to rely on them. They often know the players the best. And we all know the 3 A's: availability, affability, and ability. These are the key factors to being a successful team physician at any level. Being available to your players and your medical team. As we know, issues typically arise off hours. You know, you should be available to answer their calls, any questions on weekends, nighttime, be approachable. Affability will encourage your players and your medical team to be honest and open about their injuries and their concerns. And finally, ability is necessary. Don't accept mediocrity. You need to always be at the top of your game, constantly learning and chasing perfection. As Vince Lombardi said, perfection is not attainable, but if we chase perfection, we can achieve excellence. So over the past 20 years, I've served as a head team physician for many male teams, including the NFL, Major League Baseball, Division I NCAA teams, as well as Division III NCAA teams. And that being said, I've always said how lackluster it really is being a female team physician for an all-male team. I've never thought of myself as any different, and I've never thought of it as any different than my normal job. However, there are certainly some different challenges that we face as women, and we're taking care of an all-male team. A few that I've personally faced are finding a female locker room or a bathroom that I can use. You know, most of the underground stadiums don't have an accessible place for females to change into their game day clothes or use a restroom. So I've routinely had to change in the male locker rooms, hide behind doors, hide inside a locker room, hide inside a shower. And I've literally been caught with my pants down several times. I've also been pregnant on the sideline of NFL games and college games. I had to deal with a miscarriage actually right in the middle of an NFL game. I've had to wear nursing breast pads under my game day polos, pumped milk for my babies before and after games. I even pumped milk during Super Bowl 40 at halftime. So these are obviously experiences that men will never have to deal with. So I've learned several things along the way that I'd like to share with you to help you, to really help both male physicians taking care of all female teams and female physicians taking care of all male teams. I've also reached out to several female colleagues across the country who care for all male teams to get their input as well. First of all, you have to remember that you're a visitor in their locker room. You need to respect their space and their personal interactions. They should not need to change the way they act towards each other because of your presence. Sticks and stones can break my bones, but words can never hurt me. This was a common theme amongst experienced female team physicians who care for male athletes. Locker room talk is often R-rated, but don't be too sensitive to these comments, especially the ones that are not directed towards you. Dressing appropriately cannot be overemphasized. You know, whether you're in the training room or on the field, you need to be comfortable and professional. You need to be prepared for bending over, squatting, running on the field. Don't wear low-cut shirts, dresses, skirts, tight pants, high heels in these situations. You are the player's doctor and an advocate and not their friend. Some days the players and coaches will love you, and sometimes you'll be their enemy, especially when you have to make tough decisions regarding return to play. By keeping your socializing with the players and the coaches to a minimum, it will make those return to play decisions easier. You don't need to be antisocial. It's a fine line. You want them to respect you, so don't put yourself in compromising situations. Do and be your best. It is a job. It's like any other job that you have. You're not only the team physician, but you're also a role model for many athletes, athletic trainers, students. So again, accessibility, availability, and ability are the 3 factors that will help you to be a successful team physician. This is probably the most important. Never compromise your personal integrity or your patient care. You'll likely have situations that arise where you feel like you're being asked to compromise a player's care or your own integrity. Don't do it. Stand up for what's right. Winning is great, but you are always there to promote your player's best interests. Find a mentor or 2 or 3. The mentor can be a male or a female colleague. A mentor can be a physician, a coach, a friend. I have several that I can talk to about clinical, personal, and business-related situations or decisions. Don't be afraid to voice your concerns. Every team has different reporting structures. Some teams are run by the head coach, the athletic trainer, the owner, the athletic director. You need to understand the pecking order, and you should start with your direct boss and then work your way up the chain if you don't have your concerns addressed. And finally, this is one of the most important ones. Remember that your job does not define you. Staying in a position that you are unhappy with, or that one that compromises patient care or your personal integrity, is not worth it. So don't be afraid to make a change. Finally, thank you. But let's go back to what Billie Jean King said, that pressure is a privilege. It only comes to those who earn it. Thank you.
Thanks so much, Dr. West. That was really great. And I want to thank all 5 of you for giving such valuable talks. I think, and I hope that anybody who comes across this webinar on ViewMedi is going to leave here with many pearls about how to pursue a successful career in sports surgery.